the infection prevention and control measures. So we'll start with a prayer, and then we'll continue into the meeting. So I request a volunteer to lead us in a prayer.
Let us pray. Father, we thank you for our country, Uganda. We thank you for this day that you've given us for a time to learn. Your word says, my people perish for lack of knowledge. We thank you, Lord, that we are going to be equipped. We commit Uganda into your hands in this season. We pray that you hold the health workers. You'll enable them to follow all precautions. We pray, Lord Jesus, for your provision. We pray for wisdom, knowledge, and understanding on the part of the foot soldiers who are at the front line. We pray, Lord, for the patients in the ETUs, for the people in the quarantines. We pray that your peace and mercies will prevail and your healing hand will rove over our country. As we deliberate this morning, Father, we invite you into our midst. In the name of God the Father, God the Son, and God the Holy Spirit. Amen.
Good.
You're welcome, DG. Thank you for joining. I was speaking while muted. We've just prayed and you've joined on time. Thank you. So take me to the next slide first. We are here to create awareness amongst the healthcare workers, but also to ensure that as you offer services, once you are aware about the outbreak, you are taking care and observing the required SOPs on infection prevention and control, as we'll be hearing from the experts this morning. We also make sure that as you learn, you help us to identify suspected Ebola cases early, wherever you are working. But also you volunteer in case you develop the symptoms of Ebola, and report to the management of the facility where you work, but also use the notification lines that are readily available and will be displaying. And also address any myth that you may have about this Ebola Bundibugyo virus. Feel free to ask as many questions as you can. The teams will pick them or will be answering them online to ensure that you understand how to participate, how to prevent, how to notify, and what to do in case you are faced with someone who is suspected to have Ebola. We have three main speakers this morning. Our Director General, Health Services, is here with us. You're most welcome. He will be giving us key strategic direction on what we expect the response to look like and what we expect you to do. We'll be also having one of the commissioners who is at the forefront of managing this response, or Commissioner for Clinical Services, Dr. Roni Bahatungire, who will take us through what we see as far as this Ebola virus is concerned. And then we'll have Dr. Segilandi from Africa CDC. If I have not pronounced your name, you'll forgive me, Doctor, who will be taking us through the continuity of essential services. He's the head of continuity of essential services at the Africa CDC. And we're going to answer your questions, and then we'll have a closure by the Director General Health Services. So without much ado, EG, I'll request you to speak to us. Thank you.
Okay, thank you, Stavia, and good morning, and thank you for joining in big numbers. And I think it was very important. We've had some earlier discussions, but we thought we needed to still continue to have this engagement because all of you know that by nature of what we do, we remain vulnerable. So it's an occupational hazard, but we can be able to mitigate. For our colleagues who definitely became contacts, who were exposed, partially before the announcement or the declaration was done, is definitely quite unfortunate because probably they lowered their guard on aspect of infection prevention and control. So we'll take that probably they should be the last persons who should have to be contacts because as we speak now, a majority of the people who have had to quarantine or who have had to ask to isolate are health workers. So this remains vulnerable. We remain vulnerable, and by nature of our work, we interact with the colleagues. By nature of our work, we interact with the patients. By nature of our work, we interact with our families. But also by nature of our work, we interact with the community. So it means that if you have one health worker, in the process of coming to work, he will infect probably the people if he's using public means. When he's at home, he'll infect his family, and definitely if he's not. So that's really key, that the only way we can do this is to have the high index of suspicions. What we also need to know that Ebola Bundubujo presentation is different from those presentations of which we know about the other Ebolas, Ebola Sudan, Ebola Zaire, and all the other types of Ebola. But specifically, it presents in a very unique way and presents sometimes with the first presentation might be GIT symptoms, which might be nausea, vomiting, diarrhea, abdominal pain, and somebody can present with epigastric pain and definitely for a fever, and sometimes it can mislead us to make a diagnosis that probably you're dealing with peptic ulcers, and then we give him a cocktail of medications, and then probably can vomit blood at a later. Bleeding is really appears at the late stage of the disease. So what is key is that abdominal pain, but also what we know currently that Ebola Bundubujo does not have any vaccine. There are no therapeutics. We are just trying to repurpose therapeutics for it. So most of the treatment is supportive treatment. So it means that if you get in, you become, come in contact, it's good that you identify early or when the symptoms start so that you are started on supportive treatment. Because also we are seeing that what will kill the person so far, the ones which we have had, definitely like the case which presents one of the hospitals, he had renal failure. So kidney injury is one of those aspects which will do what? There are issues, definitely muscle injury, a lot of inflammation, which will come in. So we need that you present early. You should not hide. You should not self-medicate. So you present so that you can be supported. The last outbreak we had, all those cases which presented to us early, were able to save them. And it's the same thing. So far, the people whom we have, I must give you confidence that we are managing them, and we really would want that they walk out of the isolation alive, so that they can be able to, but we would not want more colleagues, more health workers to get exposed. So a good history, a good risk assessment, a good infection prevention, IPC is really can stop Ebola transmission, can protect you as an individual, can protect health workers, protect your patient, but also protect your family. So the capsule of the virus, as you listen or you will be told, can be denatured by soap, and if that's why you need to wash with soap and water, or it can be natured by sanitizing alcohol. So we need to be able to be able to do that. So I really would want that we protect the yourself, protect your health workers, protect your other patients, and if you get in contact, come early. So that's those are really the key aspects which we really would want that look at it. Also, what you need to know that we, by virtue of Uganda development, most of the people are coming to Uganda for medical tourism. So our colleagues from the DRC are in all the facilities in Kampala and beyond. It's not that we would want to deny anybody transport, but let's be able to articulate, take a good history, also take a good documentation so that we can be able to follow this. For the health facilities, for those who had health facilities, have a small, be able to screen, because we also, what we know is that if somebody is in the dry phase, when he has not developed symptoms, is still in the incubation period, it does not spread. But if they start developing fever and all the other diarrhea, members, can we mute? Members, can we mute? So I really am happy that you have joined. We hope that the conversation we're having will save lives. I hope the conversation we're having will protect you. But if you want you to be part of our surveillance systems, we want to get these alerts coming. Any any non-trauma deaths, we want to screen it as part of our mortality surveillance. Any non-trauma deaths, we should be able to take the samples. We are going definitely to change the protocol because we will soon, apart we've been taking mainly blood, cardiac blood, but now we might have to change, might need to take swabs from annual swabs, might need to take others because we know that the disease basically starts initially as a GIT before it gets into systemic infections. I think, Chair, these are really the key things which I want to highlight, that we can speak, but what we want, that we need to change the culture. We need to change the way we do things. If we continue doing it the same way, lastly, I think what the other aspect, which also I've seen that by virtue of the work you do, many of you are moving from one facility to one facility. And so if there's one worker which is exposed in one facility, is bringing infection to several facilities. Is moving here, moving to that facility, moving the other facility. So you find that the chain of infection spread is high. So this animal called moonlighting and moving into is going to kill us. That's also what we are seeing. We're seeing colleagues who are moving from one facility to one facility. They are bringing themselves to a risk, but also they are bringing a risk to all the patients and the other health workers in their facilities. So we want to really that to come out, and you need to be able to know that you can continue moonlighting at your own risk because it will bring you into problems. So I think those are really my key highlights that let's
If you could also
practice.
speak to the numbers that we have. I reached somewhere yesterday and people were asking me, do we really have Ebola?
Okay, well, that's also a question, because that the question is that yesterday I outed an update where we had two others, so the numbers still remain 9 with one fatality. So those are the numbers which we have. We have one patient, one Ebola patient who has been discharged from the treatment center. Those is receiving treatment in still our facilities somewhere else for different conditions, but at least it's tested negative for Ebola. So those are numbers. Most of the cases right now are still in Kampala, but does not mean that if you are up country, people from up country, don't say you are very far from Kampala. Kampala is, it's just across this country. So you need to be able. But out of those 9, we have close now to about 600 contacts. 600. About to 46 or 50% of them are high contacts, high risk contacts. So you can mean that they physically touch the patient, physically handle what? 600. So it means that if we stop, because that's also what I'm speaking to, if now you're contact, it means that if you have been asked to isolate at home, partially for level of 4 contacts, it means that even your children should not be going to school. They also mean that they should be able to isolate with you until the time when the 21 days are over. Otherwise, you'll still be putting the community into what? Into risk. So that's the implications which you have. It will affect you as an individual, it will affect you as a family, and definitely it will affect the nation. I think I've been clear, Stavia.
Thank you so much, Prof. You've been very, very clear and to the point, emphasizing IPC and vigilance and surveillance wherever we are, and also making sure that we protect ourselves, protect our patients, and our family members by observing the minimum precaution measures. You have also told us that we have 9 confirmed cases that have been reported, and we have about 600 contacts. So we need to take care of ourselves, colleagues. Now we dive into more details about Ebola virus disease. And to take us through that is Dr. Ronnie Bahatunjire, Commissioner of Health Services for Clinical Services at the Ministry of Health, and also the chair of the clinical or case management pillar in the response. Over to you, Dr. Ronnie. Hello, I hope I had, yes, thank you.
Thank you so very much, Dr. Stavia, our moderator for the day, and thank you so very much, DG, for giving us a preamble into what exactly we are dealing with. Good morning, colleagues on the call. I'm very delighted that we have all of us here, and we've been able to make over 1,000 healthcare workers who are on the call. Thank you so very much for making the time at such a short notice when we've had to invite us to come and we speak to each other, especially on matters to do with the Ebola outbreak that we are dealing with. As has already been highlighted, as healthcare providers, we are highest at risk because we are the frontline healthcare providers. We interact with patients that are coming to us with other concerns, and it's our duty to ensure that we take care of these patients. And as we take care of these patients, we expose ourselves. And the issues that we're going to discuss today pertain how exactly as healthcare providers we can offer our care both in a safe environment, safe way to protect ourselves, but then we also protect those that we're caring for. No patient should come to us and contract an infection from the hospital, and nor should we expose ourselves to the infections that patients come with when they seek care from the hospitals. So that's going to be the gist of our discussion today, and it's the reason why we talked about, as a healthcare provider, your health first. So in this outbreak, as we have seen in other outbreaks in the past, healthcare providers face the highest risk of infection because we always interact with patients at the first go when they are coming to the facilities to seek care. And that means if we have a low risk of suspicion, or if we have no any mechanisms of screening for potential infectious diseases that these patients could be presenting with, we find ourselves exposed. And that's how, as a healthcare provider, you become highest at risk in this whole entire cycle of the outbreak. And therefore, it's incumbent upon us as healthcare providers to protect ourselves as the first step in ensuring that we're able to care for those that are seeking for care from ourselves, but then also protecting our families and the community at large by ensuring that we are able to use appropriate PPE when we are caring for patients, but you can only use appropriate PPE if your risk perception is good. Uh, Risk perception is determined by your suspicion index, and two, by your desire or by your compliance to observe the principles of patient care that have been laid out in the different guidelines that we have, both the Uganda clinical guidelines, but then also the infection prevention and control guidelines that we have with us. All this is laid out on what the basic principles of patient care are, and we request that each and every time we are interacting with patients, even during routine times or what we call peace times, when we're not in an outbreak period like this, we should be observing these strict infection prevention precautions so that we do not expose ourselves as healthcare providers. So the choice of PPE will be dependent on your risk perception and your awareness, risk awareness of what exactly you're dealing with in the current times. And that's when you will be able to determine what exactly you should do and where exactly you should take patients. And more so at this time when we're dealing with this outbreak, a case definition has been produced and shared with all of us that I'll highlight at a later point in time. That should help us guide patient entry into the hospital space. When I say hospital, I'm covering the whole entire continuum of care from the lower level healthcare facilities up to the super specialized hospitals. So I'll use the phrase or the word hospital to mean a healthcare facility, right from center two up to the super specialized hospitals. We need to be seen to protect our patients by ensuring that we identify the signs and symptoms that these people could be presenting with. And we can only be able to do this if we put in place mechanisms for risk identification. And the only avenue by which we can be able to deliver this is if we put in place screening mechanisms that should be able to sieve through each and every patient that is coming to the hospitals, because you can never determine which patient could be carrying which bag, and therefore be able to protect yourself. So the right and proper thing to do is have a standard way how you screen each and every patient that is accessing the hospital space so that we can be able to increase our index of catch for those that could potentially be infectious and manage them accordingly. Mechanisms have been provided on how we can manage those that will present with signs and symptoms consistent with Ebola and any other infectious diseases. During this period of time, when we are responding to outbreaks, there are so many other incidental infections that we tend to find that we many a time would have otherwise missed. Like we previously had cases of Congo Crimean hemorrhagic fever that were diagnosed in the Nakasongola area, no, not Nakasongola, Nakaseke area, which was an incidental finding because when the samples that were drawn from these patients were taken to the lab, these patients were found to have a Congo Crimean hemorrhagic fever as opposed to Ebola, meaning that there are so many infections that are circulating in our environment, and therefore it's incumbent upon us as healthcare providers at each and every time to observe the standard precautions for infection prevention and ensure that we're able to protect ourselves. And when we do this, we will definitely be sure that we protect our families and also the community at large that comes to seek care from us. So this is in line with what we have found currently with community transmission of Ebola that is happening within the Kampala metropolitan area right now, as has been highlighted by both the Director General and the moderator in the opening remarks. Currently, we have 9 cases that have been confirmed with Ebola in the country from the 15th of May when this outbreak was declared in the country, and we have registered 1 fatality, and this was the index case that was discovered in the country. So for those that we have been able to encounter while they were still alive, we have had only 1 that presented with a severe disease, but with acute kidney injury and renal failure, which we were able to manage, and we were able to reverse, and this person has since been discharged, though she's still struggling or battling the complications that arose from her exposure to Ebola. And we have over 500 contacts that we're following based on the 9 confirmed cases that we have so far registered in the country, or that have since been registered in the country. And these have largely come from the 2 Kampala metropolitan area districts, that is Kampala and Wakiso. So what does this mean? When you look at the exposures that we have seen amongst the people that are positive currently, healthcare workers still stand at highest risk of exposure, meaning that we need to protect ourselves. We need to protect ourselves and ensure that we put in place mechanisms to protect all those other patients that we care for. The Director General spoke to the aspect of moonlighting, which happens where you find 1 healthcare provider working in more than 3 facilities. And that means if you get exposed to this Ebola bug, potentially if you become infectious, because a person will only become infectious when they start, when they become symptomatic. When you continue working when you are ill, that means you are potentially going to be exposing all the patients that are going to be caring for in all those other hospitals. And it will not only be the patients that you'll be caring for, but also your healthcare worker colleagues that you'll be working with. And it's the reason why we're saying that we need to be able to recognize these signs and symptoms early enough and report them and ensure that for all of us that will have these signs and symptoms, isolate ourselves, call for help, and that help will be offered, and you will be attended to appropriately, where you'll be taken into isolation and you will be managed appropriately. Early reporting to care, early initiation of care has proven to deliver better results with the better outcomes as compared to people who tend to wait and remain in the community and care is initiated late. The Director General hinted on the complications that we are seeing amongst our colleagues that have already been in isolation for the several days that we have seen. Acute kidney injury is one of those key presentations that we are seeing, or complications that we are seeing amongst patients that are infected with this strain of Ebola. And that means if you stay away and this whole entire disease cycle or process continues, chances of you destroying your kidneys are very high. And by the time you come, you may find that you are very far from being redeemed. And this Ebola could claim your life. So the key takeaway point from this is make sure that as soon as you do not feel well, especially by having the signs and symptoms consistent with Ebola, as we are going to see in the case definition, ensure that you report early and be initiated on treatment early. We are able to take off samples and have your results within 4 hours of testing so that we can know what exactly we are dealing with. So this webinar is prepared for all of us as healthcare providers to ensure that we are able to raise our index of suspicion by making sure that we recognize signs and symptoms consistent with Ebola and be able to take people out of the general circulation of the hospital space ensure that all these people are appropriately isolated. And as we're doing this, we need to be seen to observe strict infection prevention and control principles by using appropriate PPE and making sure that all those that are caring for these people observe that as well. And as we do this, and as we have already highlighted, these patients come in when they have challenges, especially those that will report late. Some will be having severe generalized body weakness as a result of reduced dietary intake. They need to be stabilized. Some of them will be severely dehydrated, and that means they'll be having some elements of organ damage. We need to be seen to rehydrate them and stabilize them. And as we do all this, we need to observe strict infection prevention and control and ensure that these patients are linked into appropriate care as early as possible to ensure that they are initiated on appropriate care. So this is the case definition that we have for this outbreak thus far. I do not know how many of us can see this. It may not be very clear because of the magnification that was done. But we have 4 definitions that have been provided here. We have a community case definition, a suspect case definition, probable case definition, as well as the confirmed case definition. With the community case definition as any person who will present with an illness with onset of fever and or no response to treatment. If you have had a fever for some time and you've attempted to take and
Dr. Ronnie?
yes, Dr. Sylvia, I think you lost me.
Yes, we have lost you.
Can you see me now?
Yes.
Okay, sorry about that. So the community case definition is any patient that will present with with an illness with onset of fever and or no response to treatment, and any of the signs where we will see blood diarrhea, bleeding, and blood in urine, or any history of sudden death. The suspect case definition is any person that will present with an illness of fever and or negative laboratory diagnosis for the usual causes of fever, and that includes malaria, because it's not uncommon for people that are having Ebola to present with malaria as well, malaria co-infection, or at least 3 of the following signs: headache, vomiting, diarrhea, anorexia or loss of appetite, and generalized body weakness, stomach pain, especially epigastric pain, which is being managed many a time as ulcers. Let's be keen and let's be alive to that complaint. When patients come to us and they are saying they have epigastric pain, be keen to explore further and understand what exactly they are talking about. Aching of the muscles and difficulty swallowing, as well as breathing difficulties or hiccups and convulsions. And what we need to be alive to, colleagues, is bloody diarrhea, bleeding from the gums, or any other joint, any other openings on the body are very late signs. Let us not wait for patients to be presenting with diarrhea or any other gastrointestinal tract complications and bleeding as the signs and symptoms for Ebola. By the time a person is presenting with those, that means they are at the tipping end of the disease process. A probable case will be any person who will have died in the community with any elements of a suspected Ebola virus disease and had an epidemiological linkage to a confirmed case, but was not tested and did not have a laboratory confirmed result for Ebola virus disease. And a confirmed case in this case will be a person that will present with all the signs and symptoms that we have highlighted over in the suspect case, and will have a positive laboratory result that has been done by PCR, the real-time PCR, and that is our gold standard for now in the country that we are using to confirm people with Ebola, no any other. This we've already gone through. Ebola was confirmed on the 15th, as was already highlighted. But what is important for us to pick from this slide, colleagues, is as was already indicated, we do not have any current known therapy or medicine that has been known to treat Ebola. However, what we know is supportive care is one of the things that we are doing to ensure that we keep our patients alive, and we manage the symptoms that they present with to ensure that they are kept alive. However, we are also trying out what we call we are using trial medicines, remdesivir, and later in the due course we'll deploy monoclonal antibodies to see whether there can be any sensitivity or efficacy to those non-antiviral agents. But as of today, there is no known cure, there is no known vaccine that can be used to target this Ebola virus in the country. And therefore, it's important for us to know that when we feel unwell, the earliest we institute supportive care is or the best or the better for us to ensure that we keep our colleagues and our patients alive. And in that, we also give them an opportunity to benefit from these trial therapeutics that we have available with us. And what we need to be alive to is the signs and symptoms that these patients have so far demonstrated mimic the signs and symptoms that we see with the common illnesses, febrile illnesses that we have in the country, especially malaria. And therefore, it's not uncommon that a person will have malaria, but then also have Ebola co-infection. And it's also very not uncommon that you will have the first test of Ebola being done, and the person will be presenting with signs and symptoms consistent with Ebola, and they will test negative. And it's the reason why every time we have a person testing negative for Ebola, but they have signs and symptoms that are consistent with this Ebola, we go ahead and keep them with us, and we repeat. We've been repeating after 72 hours, but basing on the recent observations that we've made, where the current statistics show 2 of the people that had tested negative at first test seroconverted after 5 days. That means that we will have to extend the duration of the repeat test for us to be sure that a person that presented with signs and symptoms consistent with Ebola eventually is retested and is cleared of any elements of exposure. And so what is expected of us, colleagues, when we encounter such people that are presenting with signs and symptoms consistent with Ebola, especially at our screening points, the entry points into our facilities, we are able to isolate them from the general pool of patients, ensure that they do not mix up with other patients, because we know Ebola transmits through contact. and we should be seen to use appropriate PPE to ensure that we stabilize them for whichever complications that they will be presenting with, and we inform the relevant authorities and have these people taken into appropriate isolation facilities so that their care can be instituted and they are cared for appropriately. Clinical presentation and indicators or risk indicators for the patients that we have so far seen of the 9. There is no specific early symptom that these patients present with, apart from the common signs and symptoms that we see amongst other febrile illnesses like fever, generalized body weakness, muscle pains, headaches, and vomiting, diarrhea coming on as the later signs and symptoms, as well as bleeding. So as healthcare providers, we need to be seen to always take appropriate history from each and every patient at this point in time. Our colleagues, we've observed over time that many of us are turning away from the basics of patient care, where we no longer take history, where we no longer examine patients. When patients come in and they give us their presenting complaints without losing time, people go straight ahead and order for investigations, and we miss out on the critical information that we could have otherwise gathered from these patients if we took appropriate history and examined them. We are kindly requesting that all of us go back to the basics of patient care and do appropriate history or clerking of these patients. Pick as much information as you can from these patients, examine them. There is a lot that we will be able to pick from these patients as we examine them that we could have otherwise picked from case 001, case 002, and the probable death that we had if the clinicians that were caring for these patients had been alive to appropriate history taking, physical examination, and even the investigations that were done. Because when you look at the labs of all these 3 people, they were consistent with a thrombocytopenia. One of them presented with bleeding tendencies, and yet they had never had any history of bleeding tendencies. So there is quite a lot that we could have picked from the history examination and investigations, basic investigations, without doing the high-end investigations, and would have been able to perhaps detect this early enough. Colleagues, one thing that we must be alive to is if we do not raise our index of suspicion, it's us that are going to get exposed as healthcare providers, and therein we'll also find ourselves exposing the colleagues that we work with, but then also our dear families back home when we return and we have picked this bug. So what is required of us, colleagues, is to ensure that we institute appropriate screening points at our facilities and ensure that we are able to tease out each and every person that is presenting with these signs and symptoms, and ensure that we are able to hold these people away from the rest of the general pool of the population that is accessing the facility, and refer these people to appropriate isolation facilities that will be able to care for them. And one of the key elements that is expected of us when we are doing clinical stabilization is to obtain appropriate IV access, because if a patient comes in and they are vomiting or they've been diarrheating and they have lost their blood volume, that means if we do not support them in quick succession, they will deteriorate and we could end up losing them. So at first contact, if you detect that this person could be presenting with the signs and symptoms consistent with Ebola and they are clinically unstable, go in and stabilize them so that as you refer them, at least the team that you're referring them to will be able to find a working IV access that they can use to stabilize and for continuous care for these patients. We need to be seen to collect samples of blood based on the appropriate guidance that shall be provided on where and how to package these samples and transport them. And as we are doing this, we need to be seen to use appropriate PPE, And we also need to test for malaria because it's not uncommon that these people will present with malaria. So if you are only looking at Ebola, and yet these people could be also having malaria co-infection, they could end up succumbing to malaria as we are screening out for Ebola. So let's test for malaria and treat it when we find it positive. But as we do all this, if you are suspicious of a sample that or a patient that they could be having Ebola, despite the fact that you're going to be testing for malaria, be keen to observe strict infection prevention and control principles. How do you take off the sample? How do you process the sample? How do you handle the waste that comes of that whole entire testing process? It should not be mixed with other waste because if it's mixed with other waste, yes, we know this is highly infectious waste, just like any other highly infectious waste, but the risk of contamination becomes higher when we are dealing with this viral hemorrhagic fever as opposed to any other bloodborne infections that we have seen in the past. For referral, we will provide mechanisms or contact numbers of the emergency medical services teams that have been gazetted to pick these people from wherever these alerts will be coming from and ensure that they are transported appropriately by people that are well prepared to transport them into or to move them into appropriate care facilities. Let us not be heroes by doing things that are going to expose us, colleagues. If you suspect a patient to be having this viral hemorrhagic fever, make sure that the appropriate team that is well trained, that is well prepared, is one that handles this event. And as we do all this, we need to be cognizant of the fact that, yes, much as we are having a viral hemorrhagic fever outbreak in the country, essential healthcare service delivery must continue. And it's our duty to ensure that we do not mix up all these elements that support us in ensuring that we care for our patients. If you have ambulances, you could gazette off one ambulance. If you must use an ambulance from your facility to refer the patient. But otherwise, the emergency medical services team has put in place ambulances that will that have been gazetted for this particular response in the spirit of ensuring that essential healthcare service delivery continues unaltered and undeterred by having ambulances that are gazetted for that function. So let's observe those principles by calling for help every time we have a challenge that we face. Infection prevention, we are expected to maintain appropriate stocks or essential PPE stocks to ensure that we are free from any elements of exposure. People should have examination gloves, people should have the gowns, and if people are going to be picking samples from the patients, then they should be provided the appropriate hazmat suits that are prescribed for that level of care. And this is a call to all of us as health managers who could be on this call to ensure that our healthcare providers are not pushed to do things that are inappropriate because of scarcity and where we are improvising. If you must do something, be aware of the risk that it carries before you go ahead and indulge. But that should not also be used as an excuse for people to avoid providing appropriate care.
Commissioner, we need to be summarizing.
Can you still see my screen?
Yes, I see your cursor. Yes.
All right. So we need to do supervised donning and doffing and appropriate management of the waste that is generated thereof. It should not be mixed with any other ordinary infectious waste because this potentially carries a higher risk compared to other highly infectious waste. And then we need to report every exposure. Colleagues, we must be honest. The reason why we advocate for a buddy system during these kinds of outbreak is to ensure that every action that happens in highly infectious exposures is reported. And colleagues are expected to be as honest as possible, not to cover up any colleague. If you were a team caring for a patient that is known to be positive for Ebola, and there is a breach, and one of the colleagues is exposed, the body should honestly be able to report this event to ensure that that colleague is attended to appropriately, so that we do not have any other multiplier exposures that could arise from that colleague. Triage workflows, what is expected of us is we need to be able to screen each and every person, separate them, and use appropriate PPE, notify relevant authorities, and escalate this care, as well as stabilizing and documenting these events, and transfer these patients to facilities that are appropriate. And the key take home from this is to ensure that we are able to screen, isolate, stabilize, and protect ourselves as we do all this in our day-to-day activities, and refer these patients to appropriate facilities when we are called to duty. So colleagues, it's important that we observe that as healthcare providers, we are highest at risk when it comes to caring for patients right now, because patients are going to be coming in with anything, as has been happening, because ill health brings patients to hospitals. And as healthcare providers, we are trained to offer care for the patients that come to us. But as we do this, we must be cognizant of the fact that, and alive to the fact that we have Ebola around us and amongst us, and therefore we must be able to watch out for any signs and symptoms that are consistent with Ebola. So we must be able to protect ourselves, we must be able to protect our patients, our families, and our communities. So your health matters. You cannot care for others unless you're healthy. And the principle of infection prevention and control is protect yourself first. Thank you, Chair. Over to you. Dr. Stabia, are you there?
Thank you so much, Dr. Ronnie, for that very detailed and informative presentation on Ebola virus and Ebola virus diseases. We'll continue to have our questions in the chat, and we'll answer some of them from the chat, colleagues from the ministry who are on from the different pillars. If you see a question falling in your pillar, please do answer it from the chat as well. We'll go to our next speaker, and this is a guest speaker this morning, like I introduced him at the beginning. Dr. Landry is from Africa CDC. He heads the Intercontinental Pillar on Continuity of Health Services. We are very blessed this morning to have you, Dr. Landry. You'll say your name is properly, Sege, to speak
Yes,
to
Sege.
the
That's
Ugandans
correct.
and to our colleagues who may have joined from other countries. Most welcome.
Thank you so much. Thank you so much, Dr. Stavia, and warm greetings from Addis Ababa, where the headquarters of Africa CDC is located. And also, I want to convey the greetings of our Director General, His Excellency Dr. Jean Kaseya, who, as you know, was in Uganda about I would say a few weeks or few days ago. He was fortunate to meet with His Excellency, the President of Uganda, to discuss the situation of the Ebola Bundibugyo outbreak on the continent. My presentation this morning comes after very excellent statements and presentations from Dr. Ronnie. I really want to commend Dr. Ronnie because he really covered all the critical points of why we are here today. And I also want to convey or warmly greet Dr. Charles Oraro, I think he also insisted in his point that we need to openly discuss what we are facing as a community of healthcare workers. We need to ensure that at the end of this conversation, we are well equipped to take care of ourselves first before we can effectively take care of our population. And I really want to convey appreciations also to you, Dr. Stavia, because it's only when we bring the information to our frontline workers, to our healthcare workers, that we can build that coalition that is needed in times of crisis to strengthen the confidence of our frontline and to our workforce to confront the crisis, to confront and to stop this outbreak. Really commendable effort that Africa Cities will also share with DRC and other countries that are at risk. As you know, we have about 11 countries at risk. Let me now move into my presentation. The next slide that you see on the screen is clearly to say the history of this outbreak started quite recently. We are today the 30th of May, and clearly you can see that we are 2 weeks following the declaration, which was done on the 15th by, first of all, by the Director General of Africa CDC, and then WHO declared what is now called a public health emergency of international concern. A few days later, Africa CDC also declared this outbreak as a public health emergency of continental security. It's important to understand why those declarations were made, because we needed to quickly elevate activate our mechanisms to not only to rapidly contain the outbreak, but also to make sure that we bring all the required commodities for our healthcare system, or all the required medications or vaccines, if they were available, to stop this outbreak. I also want to insist that, and that was made clear by the Director General and Dr. Roni, that unfortunately we do not yet have approved vaccines and effective therapeutic for this strain of Ebola virus. So it makes it clear to us that what we have left now is good public health and good clinical practices if we want to protect ourselves and if we also want to save lives. Let me move to the next slide. Now, this slide is just to let you know that as Uganda is organizing itself to contain the outbreak, to protect its people, to protect its healthcare workers, at the continental level, we are also organizing ourselves as Africa CDC, as your Africa CDC, to ensure that we bring all the African member states. We are now talking about DRC and Uganda as those countries affected, but there are 11 countries at risk identified, and the whole continent has declared a public health emergency of continental security. You are also aware that we had the meeting in Uganda hosted by the governor of Uganda about a week ago to talk about cross-border surveillance. And in that meeting, we had the Minister of Health of South Sudan. This is an illustration of why Africa CDC is stressing on the coordination to contain this outbreak, to stop the transmission, and to also save lives. This diagram just explained to you that if we want to effectively, as a continent, to stop, to contain, and to put an end to this outbreak, we need to organize ourselves. This is what we are doing, working closely with WHO. We have put in place a continental incident management support team, which is organized. I'm not going to go into the details, but you can see that we are bringing around this mechanism close to 40 partners. Those partners are now supporting our member state across pillars. So I'm talking to you today about the pillar on continuity of essential services and community health system strengthening. Next slide. This pillar, we agreed with WHO and other members of the pillar to organize it around 3 sub-pillars. Why? Because we need to first focus on ensuring that our health facilities will not face the crisis of disruption of essential services, maternal and child health, immunization, HIV, TB, malaria, NCDs, and others. They should continue. And we also agree that Ebola Bujumbura, as opposed to other type of outbreak, will affect the continuity of non-health services, like the school system. So we need to already put in place mitigation measures to ensure that the school setting doesn't become a cluster of new infection. Then the third sub-pillar we agreed was to ensure that we mobilize, we train, we protect, we deploy our community health workers. And this is a conversation that is currently ongoing with the Ministry of Health in Uganda to see the best way to deploy the VHT, not only to support contact tracing and community awareness, but also to ensure the continuity of routine community health services like nutrition, malaria screening, and others. We should not let the routine services down as we respond to the outbreak. Next slide. As I shared with you at continental level, Africa CDC and WHO have organized our partners to ensure that we provide the needed support as our member states are confronting this outbreak. You can see how we have organized ourselves to ensure that the continuity of health services is supported, the non-health services are supported, and the community health system strengthening is also mobilized. Next slide. This slide, you may recall when Dr. Roni was talking about the need to ensure that we protect ourselves first. Because when the healthcare system start to be affected by the cases among healthcare workers, it generates fear among our people, our population. So we need to ensure that we stop the chain of transmission within the healthcare facilities. We need to ensure that zero new infection or zero new case is declared among healthcare workers. It's so important also because it will address the community avoidance and the fear to attend healthcare facilities. So it's up to us as healthcare workers to put in place the effective IPC measures that will prevent us from contracting the virus, and that will also continue to build the trust that the population will have with our health facilities, because we need to ensure continuity of essential services. The other point, and this is a point that we discussed with Dr. Stavia a few days ago, is we need to ensure that the resources that will be mobilized to address the outbreak is not done at the expense of the resources that is currently utilized to provide routine services. One of the critical aspects that you will see in the organization of services is the triage. Doing the triage effectively needs more and more people at the triage point. So it means that either we have to relocate colleagues who were already assigned to other services to do the triage, or we have to recruit. We have to recruit specialized staff of volunteers who will be trained to effectively conduct the triage within our healthcare system. And this is important to discuss that openly, because that's the starting point. If the triage is not done well, if the case definition is not implemented the way that the index of suspicion, I think Dr. Roni made an excellent point on that, is used to have the highest sensitivity at the triage point. We are going to let a case get into the green zone rather than the red zone. Next slide. I want to leave this slide to you because as we discuss service continuity, at continental level, we want to encourage a discussion around the context of the country. Uganda context might be different from the DRC context. So a discussion should happen at not only at the national level, but also at district level around how do we implement a mechanism, how do we reorganize our district referral system to ensure that there's continuity of services from the primary healthcare through the district referral hospital and the tertiary level. How do we include our VHC in the conversation around continuity of services? Do we want immunization services? I think the case of Uganda may not be as critical as it is in DRC, where some health facilities in some districts where we have a high number of cases are already discussing how to bring some of those services like immunization outside the health facility, because we do not want, as you address this outbreak, to have a lot of missed doses around routine immunization. We also want, and this is a point where I want to commend Dr. Ronnie, he said on this, we want strict adherence to infection prevention and control. Let's not do any harm to ourselves as healthcare workers. If we need a commodity for our infection prevention and control, we need to make that case clear. Those commodities should be made available. That's a non-negotiable. Without those commodities, our healthcare workers are going to be exposed. And we know what to do. We have the list of equipments for PPE that will prevent our healthcare workers to become infected, even when exposed to a high-risk case. We need to ensure that as we reorganize our services, there is flexibility. Let's take, for example, how do we ensure that there's a dispensation of multi-month doses of chronic disease medication like hypertension and diabetes, or HIV medication? How do we ensure that we reduce the number of clients coming to the health facility? Also, of course, reducing the burden to our healthcare workers, because they have to manage Ebola cases, as well as they have to ensure the continuity of chronic care. We need to also look at the protection of our healthcare workers, because the body system that Dr. Roni mentioned is critical. Let's care for each other. If my colleague is not feeling well, I need to pay attention to what's happening, and maybe he may underestimate what, or she may underestimate what she's going through. We need to have an alert system within our health facilities to make sure that we don't let any colleague who is not feeling well unattended. The next slide will tell you more about how we are summarizing the organization of services. This is not new, but we really want to emphasize on this because this conversation should happen at the level of a district, at the level of a region, or at the level of a country. I know that Uganda has already identified the specialized center for Ebola treatment. Now the question is, how do we connect primary health care facilities with facilities that may be considered as red zone facilities, or within the same primary healthcare facilities or a district hospital? How do we organize the services so that when a client comes in, he starts or she starts with the green zone where he or she is screened, and that screening will either keep him or her within the green zone or move or him to the red zone? This is a critical discussion that should happen in every facility at this point in time. And this is where the risk management becomes critical, because the way you behave as a healthcare worker within the green zone is not the same as you are in the red zone. And this is where I think Dr. Roni was insisting on the need to have the highest level of suspicion and to activate let's call it the transfer of high-risk patients from the green zone to the red zone before more people are exposed within the green zone. It's so critical to have this conversation. And how do we connect the red zone to the specialized facilities? I think he mentioned the ambulance system and the need to have a very well-thought referral system to avoid more exposure during the referral to the Ebola treatment center. The next slide is also important, and I'm not going to dwell too much on this. Maybe in the interest of time, I will leave it to you, Dr. Stavia, to share with participants. It's really explained a bit in details what are the options that we have to ensure the continuity of chronic disease management. You remember I was talking to you about the multi-month dispensation. This is an option that you can consider if your health care system is overwhelmed. You may want to see how to give 3 or 6 months supply for some conditions like HIV, TB, hypertension, and diabetes. You may want to also utilize the community drop-off. I think I mentioned that. How do you activate your community health system or the network of civil society organization or people living with HIV, depending on how you're organized in your city, in your country. For maternal and child health, we need to look at options which will definitely prioritize the green zone. You remember I talked about the green zone. So how do you secure maternal health and child health services within the green zone? And how do you ensure that any mother or child with the highest, any suspicion is also screened from the green zone and moved to the red zone? It's going to be an important conversation moving forward, Dr. Stavia. My last slide, and we stop there. Next slide. Yes, this slide is a proposal. It's a proposal that we are discussing. We will discuss this slide next week with Dr. Stavia and the team in Uganda, as well as the team in DRC. As I shared with you, we are within the first 15 days. So within the first 15 days, we should have implemented the separation in green and red and the triage mechanism. That should be fully implemented within our affected districts. And the next 15 days, we need to have implemented an adaptation and decentralization system, as I shared with you, so that no excess death is recorded within the affected district due to high burden conditions like malaria, HIV, TB, and others. Especially, we should not let our mothers dying due to pregnancy and delivery because we are managing the Ebola crisis. That is not going to be acceptable because we know what to do to prevent maternal death. And beyond 30 days, we need to have a system that is very resilient and that can sustain. Hopefully, within the next 30 days, we should have been able to stabilize this epidemic. But in case we are not able, we need to have in place a resilient system that will provide continuity of maternal, child health, and chronic conditions. Dr. Stavia, this is what we prepared for this conversation. This is not the last time we are talking with your community, and we will be available for the next opportunity. Thank you so much for having us.
Thank you so much, Dr. Andre, for this wonderful talk to our healthcare team and to us, and the guidance that you bring at that level of intercontinental continuity of healthcare services during emergencies. Colleagues, we have the slides and we'll be able to share with us. You can still continue to learn and learn. We also have our guidelines. We'll be posting them on the website so that you can pick how to reorganize the services that you offer. We will now go into a question and answer session for the next 15 to 20 minutes. If you have any question you have not posted in the chat, but we shall also go to the chat and pick your questions, and they are posting them over. They are quite a number. Thank you. We'll attempt to answer most of the questions. This is the first session. I'll request if Dr. Wanai is on for gatherings, you combine all the gathering questions and answer them. Ronnie, you tell us if we have confirmed cases beyond the health workforce, beyond the health facilities. Someone wants to understand what non-trauma death is. I think Ronnie will also explain that as well. Those who are in schools, how should we have guidelines for this? I don't know that Dr. Commander, you are on call. So let's start the answer session. And as we do the answers, I request the admin to post a small poll that we have prepared for you to tell us what you have readily available to make sure that you protect yourself. Feel free to click the link and tell us genuinely what is available where you are working. So let's go to the first questions. So should Arsenal games be watched from homes? That would be the best for you and me. If you can watch from your home, that would be the best. Avoid unnecessary mixing with people that you may not know where they are. You cannot avoid touching where they have touched. So my humble answer would be avoid as much as possible to go to the crowded spaces, especially when it can be avoided and you have an alternative. Ronnie, over to you for the trauma death. What is non-trauma death, and have we had cases outside the health system?
Thank you so much, Chair, and our colleagues that are asking these questions. Very important because it means that we've been really very attentive, and that was the purpose for which we organized this. A non-trauma death is any other death that is happening at community level or in the facility and is not linked to trauma. Like we've seen in accidents, a person is involved in an accident, is taken to the accident emergency, and they succumb to the severity of injuries that they've sustained, and they die. If we're having any other mortalities other than those, we have instituted what we are calling mortality surveillance, where samples are being picked from these patients, from these corpses, just to be able to understand if there could have been anything else that could have caused these mortalities. And this is happening both at facility and community level to ensure that we do not leave any area uncovered. And this should also help us increase our scope in terms of catching any suspicious mortalities that could be happening. As we have observed, the people that got exposed at one of the hospitals in Kampala, they were exposed by the patient that they managed, and they didn't know what exactly they were dealing with. But then also, we are seeing the mortician who got exposed to the body, or who handled the body and embalmed it, also developing signs and symptoms, meaning that bodies are highly infectious. So it's the reason why we are doing these mortality surveillances, and that's the reason why we are saying any non-trauma mortality should be investigated. Have we seen any infections outside of the healthcare providers? What we have so far seen amongst the 9 cases that have been declared by the country are a linkage between all these cases. The imported cases and the few healthcare providers that managed these cases when they came into the country. We haven't had any other local transmission that is outside of this chain of people that came in to seek care from the Congo, and those that cared for them directly, especially those that participated in the cardiopulmonary resuscitation of this patient, the probable case shortly before he died. Thank you. Back to Chair. Chair, maybe if I'll be allowed another opportunity to come back, I have a short video of 2 minutes that I'll
I think there'll be we'll take these questions into the most frequently asked questions if they're missing, and we'll be also sharing answers to them. So we'll share with the team. How long does the virus remain available on the surface outside humans? Talk about blood donation. Yes. Share with us here the contacts of the team leads at the treatment centers. We have a toll-free line, which we are going to share with you. It is the most immediate tool you have to reach us. In the chat, if someone can type it there. It may be difficult to share all the contacts of the case managers, but Dr. Ronnie's contact is available as well. You can post it, Dr. Ronnie, in the chat, and maybe the one for Alan. What is done to prevent more entries from Congo? What is the incubation period for the Ebola virus? Looks like all questions are linked to the presentation of Ronnie, most of them. Does soap alone, is soap alone enough? Or we need jig as well? How do we dilute the jig for hand wash? You can hear the questions, colleagues. They are very, very nice questions. I request to be added. That one we shall do. Need clarity on the screening point level of protection. I think this is to do with PPE. Type of mask for staff at the screening point. If the mask is necessary. Is it mandatory for all clients that come to the hospital to wear a mask? Of course, no. This is not COVID-19. This is a contact disease, colleagues. You touch contaminated material. It's not an airborne disease. So we'll be providing detailed answers. I don't know if you can wrap up the many other things that have come up related to PPEs, the level of application, the time the virus stays on the surface, and the incubation period. Is sex greatly affected by Ebola? Even that one is very important because when we discharge, the virus stays in the semen. So Ronnie, go ahead again.
Thank you so very much. Once again, colleagues, the incubation period of the virus that we are working with currently is 21 days, meaning that if you've been exposed, it's until after 21 days that we can be sure that you are virus-free, meaning that at any one point in time in that period, you could seroconvert. So you need to stay vigilant and ensure that you report any signs and symptoms that emerge in that period of time. How long? The other is which PPE is appropriate for use. We have different levels of exposures, and we have different levels of PPE that are guided depending on what exactly is being done. If you're conducting a screening, if you're manning a screening point, all we need to have with you is as long as you're keeping your distance, have your gloves on, your examination gloves on, and keep taking the temperatures and documenting the temperatures of the people that you have screened into a log, and ensure that you do not share any of your items that you're working with, if it's a pen or anything, so that you can minimize any aspects of cross contact that could potentially expose you. And what we need to be seen doing at each and every of these points is strict hand hygiene and ensuring that you minimize as much as possible picking any bugs from across your people that you're going to be handling. If you're going to be examining patients on the general and you assess that the risk is low, you can use an apron, you can use the examination gloves, and you will be safe. If you're going to be taking off samples, if you're going to be caring for patients, if you're going to be manipulating the patient to either cannulate or do anything that is going to bring you into close contact with the patient, we expect you to use a level 4 PPE where you have to don a hazmat suit complete with the hand surgical sterile gloves, gumboots, and goggles, as well as headgear which comes with the hazmat suit because the risk of exposure at that point in time is high. So PPE, that's the reason why we use the word appropriate PPE, is determined by your risk assessment of what exactly you're dealing with. We do not expect people at the screening point where there is no or minimal contact with patients that are coming into the facility to start wearing hazmat suits. And the hazmat suits, which is level 4 PPE, is reserved for people or healthcare providers that are going to be having a direct contact with the patients that have been found infectious or the suspects that have been isolated.
So thank you so much, Dr. Ronnie. What measures have we put in place for Congo? We are doing our best as far as border surveillance is concerned. I don't know whether Dr. Alan, you are in, or Dr. Bernard. But also we closed off the people movements. We only allow cargo and food movements across the borders. But by the time we did that, the first cases, of course, had already come, and some of them suspects are already with us. So we need to deal with those who have already reached us. Let me hear from Peter, Judith, and Akena in 1 minute each, starting with Peter.
Yeah, thank you so much, Dr. Stevia, for giving me the opportunity. Mine is to say that this outbreak should be theoretically a lot easier to contain than the respiratory COVID, because it's about touch. And given that, I'm appealing to the DG and Dr. Ronnie to consider giving the private clinic a subsidy for gloves, urgent subsidy, because on a daily, even without the outbreak, gloves are a high cost item for us. So if you give us a subsidy, we are ready to buy and make them available, and they will protect our people. And I'm sure the many donor partners who can actually willingly give us these things for free. So Mr. DG and Commissioner, can you please consider that urgently for the next 6 to 8 weeks? Over.
So much. Peter, you bring a very valid concern. Most of the health workers are working without gloves, especially in the private facilities. Judith, go ahead.
Yeah, thank you very much, Tavia. Thank you very much, Dr. Ronnie and Dr. Landry, for the presentation. I'm Dr. Judith Kose from Africa CDC, based in the Eastern region. So I wanted just to bring another angle to what both Dr. Ronnie and Dr. Landry presented in terms of keeping safe, but also keeping our clients safe, especially mothers and children. One of the issues that has been raised in one of the forums is how do we handle a pregnant mother or a lactating mother that is exposed and perhaps is symptomatic. So what do we advise them in terms of, and I'm thinking about Dr. Landry, what you presented in green zone and red zone and referring the patients. So what happens to a mother who is whose baby is who's exclusively breastfed, but the mother is symptomatic and exposed? How do you handle those, or do you separate them in terms of the safety? So I don't know if maybe either of you can speak to this in terms of guidance. Thank you.
Akena? Akena, we are not allowing more hands, colleagues. We gave ourselves 20 minutes to the questions. Type your questions in the chat. We shall pick it and we shall provide an answer. Dr. Edson, don't put your hand down. Akena is not speaking. Edson, go ahead.
Hello, Judith. Hello.
Let me.
Hello.
We
Hello.
can hear you. We can hear you.
Judith. Thank you so much. This is Dr. Kenna again. Sorry for the interruption. I work with the UPDF, that is the Bomba Military General Referral Hospital. I had a question for the presenters, and this is I realized they mentioned the issue about one of the complications you get with this Ebola virus, the bundibujo, is the kidney failure. I was concerned if there's a specific management in case you have a client with this kind of condition, with acute kidney failure resulted from a bundibujo Ebola virus. So do we have experts involved in this area to guide us how we manage with IV fluids and all that, and how we can make sure we save these patients? Thank you.
Okay, thank you. Dr. Edson, please go ahead as we close the question session.
Thank you, Commissioner. Mine is a recommendation to the biggest problem, which is fear of health workers and fear of the community. And most fear comes because they don't know what to do. So I was recommending that through our regional teams, the districts should be well trained. After being trained, they go down and train health workers on what to do. The health workers will go to the village health teams, the task forces at the village level, so that when a suspect is identified, the community knows what to do. The household knows what to do. The health worker at the lower health facility knows what to do, and everybody doesn't fear this patient. They just help the patient to reach at the designated health facility. So if we can do that, I think we can support our country very well. Thank you. Over to you, Commissioner.
Recommendation were taken. The EG in his closing remarks will further substantiate on that. Wawire, you still want to ask your question? You don't want to type it. Please go ahead, John.
Thank you so much. All protocol observed. My concern is we sometimes involve these VHTs in these programs which run. For example, the past COVID-19 which we went through, VHTs were involved in connecting the clients to the hospitals, but they end up not being paid, or they are just underpaid. What have we put in place to curb that gap? Thank you so much.
Thank you. That is taken note of. So thank you all for the questions, Sergey and Ronnie, and then we'll go into the closing session.
Dr. Stavia, do you want me to come in first?
Yes, go ahead and make your comment, then Ronnie, and we
Yeah.
shall go into the question.
Yeah, thank you so much. I think I want to focus on two important points. The first one being, how do we reorganize our client pathway, our services within the principles of green, red, and referral to the ETC, Ebola Treatment Center. I think that's an important consideration. And if you want to focus on a specific group, right, the pregnant mothers or the pregnant women, you may want to have that conversation with the district management team, as well as the expert in maternal and child health within the district, because there's no one size fits all, but there are principles that we need to respect. I mentioned that in my presentation. So you really need to go through those principles, the principles of do no harm to the healthcare workers, and do no harm to the mother and the child. Really, really, really important. This conversation today is also emphasizing the availability of the commodities. When we talk about commodities, it's also the commodity to do screening. You need those thermometers, those pistols, because if you want to ensure that the screening is done at the point of entering the health facility, those people that will be positioned there needs to have the right equipment. And they also need to ensure that when they screen the mother or the child coming for maternal and child health services, they need to know the criteria for suspicion. They need to be well trained about it so that the mother and the child are well taken care of. Now what will be a critical issue is if the child is let's call it at risk, or identified as a potential, as a probable or a suspect case. What do we do with the mother? I think we need to always treat the mother and the child paired together. There's definitely going to be a high risk of suspicion for the mother if the child has a fever or if the mother has a fever. We need to really continue to keep them together. Now, within the red zone, the experts in the country will have to decide or to guide us on how they will approach managing a mother and a child if one of them is at high risk and needs the other. This is especially the case for breastfeeding mothers. I think those are critical case by case issues that may need to go into the in-country guidelines. But now my last comment is related to the concern around what do we do in the management of kidney failure. I think we need to understand that kidney failure comes in most cases as a complication of late attendance. It comes as a result of severe dehydration. So I think one message we need to put clear to our community as well is that early attendance to the healthcare facilities will also prevent the occurrence of such complications. Over.
Thank you so very much, Chair, and thank you so much, Dr. Kawanguzi, for the questions asked about, actually, it wasn't a question, but it was an ask for the Ministry of Health to support private healthcare providers to subsidize the cost of PPE. This is going to be considered, and it will be presented to the National Task Force or the Ministry of Health top management to guide on how best we can go about with this. The Director General is here. Perhaps he'll be able to speak to this, but we will take this through because, as was highlighted, we've been doing support supervision in the Kampala metropolitan area. And one of the key findings that we have is people are not observing the basic principles of infection prevention and control. And many a time, people will cite expenses as one of the inhibitors of observation of these principles. So we will try and see how best we can work together to ensure that we are able to support you. When you're not healthy, when your healthcare providers get exposed, the whole entire Kampala is at risk, because those same healthcare providers that you're working with also share in other workspaces, especially in the public sector. So we could find a crossover of or an overlap of infection transmission from the private sector into the public. So we are one healthcare workforce in this country, and we will be viewed as such. There was a question on how long the virus stays alive or viable on inanimate surfaces. Literature that I've been able to come through with is states that these viruses can stay viable for up to several hours, 7 to 10 hours on inanimate surfaces like door handles, worktops, and everything else that is inanimate, and that they can be destroyed when we use alcohol hand rub or alcohol-based hand sanitizers to make sure that we decontaminate or we continually clean these surfaces. However, when we find infectious material like blood, vomitus, or stool that remains wet on the down surface, despite a drying of the top surface, the viruses will remain viable for up to 7 days. What we need to be alive to is we are dealing with an RNA virus, which is easily destroyed by any of these interferences, like if you use alcohol or any form of disinfectant. So the reason why we are guiding that we should observe strict hand hygiene during this period of time and even in the future. We've learned these lessons since the COVID-19 era, and we need to continue with these practices as a new norm going forward. Chair, I have a very short video to show on why hand hygiene is very critical, especially during this time and even during other peace times when we are dealing with especially multiple organ resistant organisms. If I may be allowed to show it so that all of us can be able to share in this space with these basic principles.
I think you can share it or give it to the admin to do so. I want to thank you, our dear presenters, for the wonderful work you have done this morning, and our participants. We have posted the link for you to share with us the situation of masks, gloves, and so on in the chat. Take off time to fill in that form as we also get the video from Ronnie, and then DG be preparing to close off the session. How long is the video, Ronnie?
2 minutes.
Okay, 2 minutes. Please stay on for 2 minutes as we wait for the final closure. Thank you.
Dr. Ron, there is no sound in the video. You could share it with me. I can quickly put the sound if you need help.
Isaac, I've shared it with you.
Okay, thank you. So as we put the video on, key things that we have learned this morning. The need to stay safe for us to be able to continue offering services. You may need to make money today, but you have to be alive for you to make the money. So safety is first, like the theme is. But also, even beyond the outbreak, we'll need to continue observing these safety precautions for ourselves. Because most of the times, we have had to get Ebola in our health facilities, and usually we get it when we are not suspecting. So the precautions that we are talking about should be part and parcel of the process of caring for patients. The video is ready to start. Please go ahead. I'm just talking. But what is important, we need to make sure that we do not neglect to offer the service that we are keeping safe. Otherwise, we'll have more deaths from the common conditions that we have: malaria, pneumonias, maternal child-related issues than the Ebola outbreak itself. So let's put the precautions in place and continue to offer the services and make adjustments when we see that the population is not reaching out for our services to make sure that they are accessible. Let's go ahead with the video. Thank you so much.
Video.
Yes, and let's saturate the video in the different chat rooms. You can also post it in the chat here that people can pick it. I am very, very, very happy that we all were able to join and stay on. We still have over 800 people. We are grateful that you prioritized this session. DG, I now invite you. We'll continue to have these sessions. Please always mobilize so that we keep alert. And the recommendations that we have picked, we shall also see how to put it in practice. Over to you, DG. Dr. Lara, are you on? Professor Lara, I'm sorry, are you on?
Dr. Stavia, the DJ is not on the call.
Okay, the DG is connecting. I think he was pushed out of the meeting because of the numbers. At the time when we had over 1,000, sorry about that, DG. I hope we have filled the form.
Yes.
Good, thank you so much.
Please
And,
share the link for the form.
share the link of the form. Kindly, Isaac, keep sharing until you have a good saturation.
Oh, Stavia, Chair.
Yes, now you can go ahead, DG. We have completed the sessions and the answer session. We got key asks, one from the private sector that if you could subsidize the gloves, they can easily acquire them. Or if there is a partner who can support them, because it makes one of the most expensive items they have to use. And then one of the DHOs posted that if it's possible, we cascade the capacity building to make sure that at regional level, they train the DHOs and the DHOs train their health facilities and facilities the VHTs, so that we have the country all primed in terms of awareness to the Ebola virus. Over to you, DG. May it be muted. Isaac, kindly unmute the DG.
Oh, okay. Thank you, Chair, and thank you, members. And I think it has been a. I want some. We'll look at those asks and we'll look at it, because we would want to prevent infection from and wherever it happens, because that doesn't make good sense for us to be prepared in the public and we're getting gaps in the private. But so I think we'll continue to engage. I might not be able to confirm it in this meeting, but we'll look at all the different partners who are working with us to see how they can be able to come in to support the private sector. I think information is key. So, but the theory which we have learned is different from the practice. So let's see differently how this translates into what we do on a daily basis. And I think also I'm happy that we have shared on the continuity of essential services. It's really one of those things we really want to drive. Sorry for the noise in the background, but I want to look forward that we'll regularly continue to engage. So if we have, I hope also we share the different lines where you can be able to communicate, any alert, communicate any information. but we remain available. So let's protect each other. Let's be our own brothers keepers and see how we move. We really would want to bring this outbreak to an end as early as possible so that we can open our country and so that we don't get this wallable where every other country wants to close us. I think I'm seeing it the first time. We've had this the 9th outbreak of Ebola, and the world has not closed before, but look like this time everybody wants to close us out. So let's see, and we can only do this if we are able to know that all the contacts we have them. And we would be happy if we have the contacts only who turned positive are in the quarantine, or we already know them. Because if we have contacts, I mean, those positive cases which come out from the community, they change the ball game. So I'm really looking forward to your support, and it's only through your support and that's when we can bring this outbreak to an end in the shortest time. So let's continue the conversation. Thank you, Chair, for convening this.
Thank you so much, Director General of Health Services, and thank you, everybody. Meeting adjourned. Over.